So after understanding the basic VA and VV ECMO, we go to bit complex hybrid ECMO. But before going to the talks on hybrid ECMO, I'll just go through how the nomenclatures of ECLS has been done. You know that nomenclature is definitely essential for making it standardized and for literatures and or for research purpose, you require a standardization of the nomenclatures. Okay. So basically, the drainage and return cannula is separated by hyphen, where left side is always a drainage and the right side is the going to be a return. So we what we tell. Whenever you put an additional cannula, okay, if the flow is minor, then it is labeled as a small letters. If the flow is bigger, major, then it is going to be major with the big alphabets. Okay, and usually you required for either a second additional cannula, third cannula usually required either for a additional drainage or unloading of the specific anatomical locations or distal perfusions. Okay, so you can have a VVV or VAA or VVA ECMO. Okay. Dual lumen, you always put DL before the VV ECMO, so it's doing DL VV. Okay. Now, suppose you want to label which vessels you are cannulated, then it's going to be a small letter in a subscripted form. So it is going to be VF or AF or VFVG. VFVG means with femoral vein for a drainage and femoral jugular vein for a return. Okay. So these are the different nomenclatures been used, abbreviates which has been used for a cannula. Now this is going to be important when I come to the next different hybrid ECMOs. Okay. So now, as you understand, types of ECMO, basically there are two types of ECMO. One is VA ECMO and second is VV ECMO. And then, depending upon the requirement, they are further modified into a hybrid or versus a variants of ECMO. What are the different hybrid ECMO and variants of ECMO? So the variants of ECMO is the mode remains the same. It is not the mode which has been changed. The mode remains the same like VB ECMO or VA ECMO, but you need to put an additional drainage, vascular, or the equipment has been changed. So VVV is, the mode is same, VV ECMO, but you require an additional drainage. So it becomes two drainage, when draining from two vein and returning to one vein. So that's going to be VVV ECMO. Similarly, you might be on VA ECMO and you require an additional drainage, then it becomes VVA ECMO. Okay. Another variant is going to be ECCO2R removal. That is basically a kind of a VV ECMO, but here the oxygenator is only capable of removing the carbon dioxide because they are low resistance of oxygenator, which is surface area which is very low. So it can just, the flow can only pass around 800 to 1 liter flow can go through and it can remove the clearance the CO2 while the oxygenation does not take place with the help of ECCO2. Now, what is hybrid ECMO? Hybrid ECMO is the two types, modes of ECMO are combined. So you have a combination of VA ECMO plus VV ECMO. So both are combined, VA plus VV ECMO. So this hybrid ECMO supports both heart as well as lung. Okay. So it can be VVA or can be VAV or it can be VVVA or VVAV. Okay. So coming back to the variants of ECMO. So when you have a VV ECMO, you require an additional drainage cannula and you put additional drainage cannula. So you can see here, there's a drainage from the femoral vein, there's a drainage from the IJV, and the return is going to the RA. So this is VVV ECMO, where you have additional drainage, and that is because the drainage is not sufficient, or there's a high recirculation, and that's why you go for a VVV ECMO. And again, remember that this is only for the lung support. VVA ECMO, again, you have additional drainage. You have got two drainage from IVC and SVC or the RA, and it gives a better drainage. If you require the RV is not getting completely collapsed, then you require for better drainage of RV, and you have to have two cannulas drainage and one return cannula. That is VVA. It is only for a cardiac support. The advantage of this VVA is when the heart starts recovering, you might switch over to VV ECMO easily. Hybrid ECMO, it supports both heart as well as lungs. Mostly required during an ECMO run, but it can be even planned from the initiation of ECMO. So usually you are going for either a VA ECMO or VV ECMO, but in between, suppose your heart or lung condition again deteriorates, then you might require to go for a hybrid ECMO. Sometimes we might require hybrid ECMO from initiation also. Okay. So when the cardiac patient requires lung support or when the respiratory patient requires cardiac support, you have to go for a hybrid ECMO. So what are the indications when we require hybrid ECMO? Okay. It is required from the initiation. You might require hybrid ECMO when the patient is in septic shock with ARDS, with severe ARDS, inotropic score is more than 100. In that case, you might have to go for a VAV ECMO because we want to support both heart as well as lungs. Or in case of myocarditis with ARDS, where there is a severe ARDS, like in case of dengue or H1N1, and they have got significant myocarditis also. So you need to support both heart as well as lung. Then you can go for a VAV ECMO. Or you might require to go on VAV ECMO when patient is already on VV ECMO. So when the patient is on VV ECMO, he requires cardiac support, like in case of patient delta goes into cardiac arrest, you might have to go for VAV ECMO. If patient's cardiac condition deteriorates, as what we discussed just on RV stunning, or in case of right heart failure, or in case of severe pulmonary hypertension, or patient goes into septic myocarditis, again he requires some kind of cardiac support. Or when the hemodynamics are unstable, like patient is going into sepsis and septic shock, then you might have to go for VAV ECMO. Or in case of refractory hypoxia, which needs correction, that is most important. If there is a refractory hypoxia, but lactates are fine, you may not do anything. But the refractory hypoxia with the lactates are going high, unstable hemodynamics, patient becomes acidotic, then in that case, you need to correct that and you might have to switch over to VAV ECMO. Or when a patient is already on VA ECMO and patient develops, requires some respiratory support, like patient develops Harlequin syndrome or what is called as north-south or differential hypoxia, or patient develops patient is in a cardiac stunning, but he requires a better coronary perfusion, or patient in a VA ECMO, it's little hypoxia because the Harlequin syndromes to decrease the lower neurological injuries. Now, how this VAV ECMO helps, if you see the patient already on VA ECMO, this is a study by Zoe et al. In hybrid ECMO. What it shows is that when you convert the patient to VAV ECMO, if the patient is only on VA ECMO with the zero flow in the venous system, then your saturation remains, the left ventricular saturation remains around 70% and the PO2 is only 45. But as you increase the flow in the venous counterpart, as your flow increases in the venous counterpart, you see simultaneously your saturation also starts improving in the left ventricles. So that is the way your VAV ECMO helps. This is in a cases where there is a differential hypoxia. So increasing the venous flow improves the saturation in LV and pulmonary artery. Okay. So how the hybrid setup is going to be, okay, in VAV, or what is the difference between VVA or VAV? There's no actually difference. When you switch over from veno-venous to hybrid mode, you see it's a VVA. So that you know that initially to the VV ECMO and then switch over to VAV or VVA. And if there's a VA ECMO, then you switch over to hybrid mode, it becomes VAV. Okay. What you required is additional return cannula, and it will support both heart as well as lungs. Okay. Now, what is VA or VVV? It is both. When you require two drainage and two return cannula, it becomes VVVA or VVAV, depending on which is the primary mode of initiation of ECMO. Now, another thing is that what will be the configuration, how they are labeled. They are labeled depending on the configuration also. You might have a double lumen IJV and subclavian artery for a VVA ECMO, or you might have a double lumen IJV and femoral artery as a VVA ECMO. So that is another combinations. Now, these are usually subclavian and artery cannulation is usually being preferred with double lumen, in case of patient is awaiting the transplant and mobilizing the patient, that becomes easier. Or you can have femoral vein, femoral artery, and IJV as a combinations. You can have pulmonary artery cannulations, or you can have a left atria with transseptal approach. These are the different vascular access you can use for a VAV ECMO. So this is what to drainage from VV. There's a variant of ECMO, VVA, VVA. So there are different combinations you can use it. You can use it from drainage from IJV in the femoral vein and return to femoral artery. You have drainage from both the femoral veins. You can go by both the femoral veins and return to the femoral artery. Here you can drain from the double lumen IJV and return to the femoral artery, becomes VVA. Both the lumens of IJV has been double lumen has been used for drainage. Okay. Then you can have VAV, where you drain from femoral vein, return to femoral artery, and return to IJV. So becomes VAV. So these are the different combinations that can be used. You can use a double lumen jugular, drain it from the one end, and send return to the double lumen return cannula and the femoral artery. So these are different combinations you can use for cannulations. Okay. The advantage of, as I told you, the IJV plus subclinic is it becomes a walking hybrid, and this is usually been done when the patient is waiting for a transplant. So this patient can be mobilized easily. Okay. Well, if you are using femoral artery, mobilization becomes little difficult. It's not that you can't mobilize, you can still mobilize, but it becomes there's some limitations in mobilizing the patient. Or you have VPA cannula. That is what, as I told you about the protect cannula. If you have protect cannula, double lumen protect cannula, you can put the cannula in the drainage from the RA and return to the femoral artery. Or you can use two cannulas where you can drainage from the femoral artery or RA, and the return cannula is put in directly to the pulmonary artery. So that is the configurations VPA configuration. Or you have a hybrid mode ECMOs with the transseptal configurations. So where you do atrial septostomy, and that is usually required if there's a refractory hypoxia is there, then you require atrial septostomy in case of VV ECMO, or with a severe pulmonary hypertension is there, or patient with a VA ECMO, you require patient is in a cardiac stunning, so you require to do a LA venting. So you do a VALA ECMO where you put on another do a transseptal puncture, put a cannula in the LA and drain the blood from the LA also. Okay. So when you talk about this different ECMOs, hybrid ECMOs, what are the percentage of hybrid ECMOs required in adult respiratory ECMOs? Is hardly 1 to 2% of them require hybrid ECMO, and usually those patients who require hybrid ECMO, the survival is significantly low because what is happening is these patients are usually very bad because they are severe ERDS plus they have cardiovascular involvement also, so they are bad pathology and the chance of survival are less. So when you see the ELSO data of VA ECMOs, okay, pediatric, respiratory, and the neonatal, adult, neonatal, and pediatrics, all the patient who requires hybrid ECMO is 3 to 5% of the patients require actually, and they have a better survival. The reason is because most of the time they require hybrid ECMO because of the heart is improving, the lung is still not improving, like in case of Harlequin syndrome. So there, the outcome is usually better because heart starts improving. In case of ECPR, when you do adult or pediatric ECPR cases, hybrid ECMO requirement is in again 2%, and survival is again going to be better. Okay. So these are the data from the ELSO registry from 2013 to 2018. Where the number of patients who required total number of patients who required hybrid ECMO is 580 patients, and the survival was around 40% in overall. But if you see, the survival was better in neonatal ECMO, and pediatric ECMO as compared to the adult ECMO. Okay. Another study by University of Michigan is that shows that there are 8 patients of pediatric ECMO require hybrid mode, and 23% requires in adults requires an hybrid ECMO. And if you see the survival in case of the reason for hybrid ECMO is usually most of the time pediatric cases is not sourced or differential hypoxia, but in adult patient it is basically a VV ECMO which requires to convert into VAV ECMO because of the cardiac failure. Okay. And the survival, if you see the pediatric case survival is much more because it was a VA ECMO which was converted into VAV, while in adults it's a VV ECMO which gets converted to VAV, so survival was less in that. Now, how will you manage this VAV ECMO? Now, what you require is, you require an additional equipment to manage this. Now, what happens is this is a Hoffman's clamp, and that is required to regulate the flow. Now, why you require to regulate the flow is because there's a Y connector in the, you require a Y connector in the, this is another picture, yeah. So what you require is, you require a Y connector here. Can you see the Y connector here? This is the Y connector you required in case of in a return line, so that you can give a blood partly to the artery and partly the blood goes to the vein. Now, as there's a less resistance in the vein, what will happen by default, the most of the blood will go to the venous system. So to maintain the good flow in the artery, what you need to do is you need to partially clamp the venous line also, and that you can do with your regular clamp like this. But then there's a disadvantage is it is not constant, and second thing, it can damage the your tubes, and that tube might start leaking from that side. And second option is you put a Hoffman's clamp, what I showed you just now. You can put that Hoffman clamp. Okay. Second thing you need to do is, because there is an increase in the circuit length and there is an increase in the turbulence, because there's a Y connector here, there's an increase in the turbulence. So what you need to do is you need to increase the heparin requirement, and you have to increase your target acid. So usually we keep the target acid here around 200 or so. Okay. So what are the problems with the managing VAV ECMO is increased risk of thromboembolic phenomena, that you require Y connect, because you require Y connector. So there's a turbulence and that can increase the thromboembolic phenomena. Bleeding risk will increase because patient is already in VV ECMO, is on heparin, or VA ECMO and heparin, and you have to additionally put in cannulation, do a cannulation, so it becomes that. And the bedside complexity increases, this because new cannula is added, new circuit is added. So, and your staff may not be tuned for that, so that will increase the complexity. Okay. Now, what are the things you should look for is, you have to look for clot formation, whether it is taking place. You have to see whether any tube is getting kinked, whether the flow is getting distributed properly, and you have to at least maintain 1 liter of flow in every limbs in adult patients. So in a venous side also, you should maintain 1 liter of flow, and arterial side also, you should maintain at least 1 liter of flow. Otherwise, the clot formation can take place in the arteriovenous side. There'll be more stop cocks, more pigtails, more sutures and fixing sets, and that all can create more problems. The advantage of this is, once the heart starts recovering, okay, you can switch over to VV ECMO because the lung is going to take usually longer time than to recover as compared to the heart. So usually heart recovers in 5 to 7 days, and then you can switch over to VV ECMO from VAV ECMO. Okay. You have to be mindful for flow both on venous side as well as arterial side, and to increase the target ACT. Okay. So in short, if I say, you have to always ask yourself which mode of ECMO you want to go for. So the only one question you need to ask yourself is, what organ required support? If you feel that only lung required support, go for a VV ECMO. If you feel that it's a heart which required support, go for a VA ECMO. And if you feel that both the organs will require support, then go for a VAV ECMO. Now I'll just simplify it. Suppose a person has got a dilated cardiomyopathy and his ejection fraction is 25%, and now he develops ARDS. And he comes to you with ARDS, it's a very low PF ratio, type 2 respiratory failure, respiratory acidosis, moderate inotropic supports, and ejection fraction 25. Now, this patient requires only lung support, because ejection fraction of 25 is an old story. Now his hemodynamic disturbances is basically because of the respiratory, acidosis, and metabolic factors. So this patient just requires lung support and go for a VV ECMO. Okay, but the same patient, suppose ejection was normal and now it is less than 25%, then in that case, this patient might require to go for a VAV ECMO. So there are different types of ECMO and cannulation strategy. Okay. So at the initiation, you might go for a VA ECMO, and your cannulation strategy is one drainage cannula and one return cannula. You can use either femoral vein and femoral artery, or subclavian artery or axillary artery, whatever you want to use. In case of VAV, you might require to go for initiation with VAV ECMO. In that case, you require one drainage and two return. In that case, you require one drainage and two returns. Okay. So drainage is going to be femoral vein or IJV, and return can be femoral artery and IJV, or subclavian artery and IJV. Okay. Or you have to go for a VV ECMO, again one drainage and one return, femoral vein and IJV, or both the femoral veins you can cannulate. Now during ECMO, the patient is already on VA ECMO, and if the patient requires to switch over to VAV ECMO. Now that usually required in case of differential hypoxia or Harlequin syndrome, or also known as North-South syndrome. Okay. Or you might have patients with on VV ECMO and requires to switch over to VVA ECMO, and that usually requires when the patient develops cardiac failure, especially the right heart failure or even left heart failure, for whatever the reason may be, or severe PH, you might need to switch over to VVA ECMO. Okay. So what will the VAV configuration? Okay, it can be VVAV or VVAV. Okay, so here two drainage and two return cannulas will be required. Okay, and indication is both heart and lung failure with additional drainage you require. Or it can be VLA. So what is required? Yeah, the two drainage cannulas are there. One is femoral vein, draining from femoral vein. One is draining from the left atria. This is you required in case of when there's a cardiac stunning and you want to put a LA vent. Or you can have VAPA. So again, one drainage and two return. One is in femoral artery and second is in the pulmonary artery. Okay. That you usually require to do for RV failure. It is something like you are converting like a bived. In VV ECMO, you might try to do VPA. So you have one drainage in the femoral vein and one return in the pulmonary artery. What I talk about, or you can use dual lumen protect cannula. So that is usually done for RV failure or severe pulmonary hypertension. Or you can have VVLA. Here, one drainage and two return. One will go to the IJV and second will go to the left atria. Again, that is for refractory hypoxia or RV failure or PS. So you are bypassing the right heart. Or you can go for VV atrial septostomy. So you don't have to put additional cannula. Atrial septostomy will itself give a flow. Again, the indication is refractory hypoxia with right heart failure or PH. Or you can have a double lumen VV ECMO. Okay, both are in IJV, and that is what you do in any of the VV ECMO cases. Okay. So the factors which determine the type of ECMO is, as I told you, organ you need to support. Okay. If you want to unload the heart, go for a VV ECMO. If you support the want to support the lung with the heart normal, then go for VV ECMO. You need to support both, then go for VVAV ECMO. And you need to support only CO2 removal, then go for ACCO2. Okay. Condition at the time of initiation is again important factors. Patient is in cardiac arrest, there is no other choice. You have to go for a VA ECMO. Patient is a severe hypotension, okay, with inotropic score more than 100. Again, you have to go for a VVA ECMO. Even the patient is the severe ARDS. So, okay. Another important point is availability of vascular access. Okay. This is the problem, especially in the neonates and pediatrics, small pediatrics. Suppose patient is a respiratory ARDS cases, but you don't have double lumen cannula, weight is less than 10 kg, so you cannot use the femoral veins or femoral vessels. In that case, you have to go for even VA ECMO in spite of patient is going to be a case of ARDS. Okay. And the last thing that depends on the experience and comfort of the centers. Okay. So hybrid modes of summaries, hybrid mode of ECMO are uncommon but more flexible, and it involves most possibilities. It supports both heart as well as lung. Probably this is going to be the future when many of the patients we might require to support RV or LV venting. So we might start using more and more hybrid ECMOs. Okay. And usually prefer to go by percutaneous as a minimum invasive approach. Okay. Issues, as I told you, new cannulas, bedside complication increases, and depends on the local experience.
खत्म हो गया लेक्चर।